All right, good morning. So we finished talking about 3, 4, and 6 last time, and now we're going to say a little bit about eye movements, which we'll come back to quite a bit in this course. And now we need to kind of tie together how the cranial nerves act, and then as well as circuits that are involved in the brainstem and brain to coordinate eye movements. So we'll talk about 3 types of conjugate eye movements. Conjugate means your eyes are working together, all right? And so there are 2 that fixate the image on the retina. Okay, so for example, if we're having a patient, you're holding out your finger and you're having the patient, okay, follow my finger. All right, so you need to see that, right? So this is a pathway that comes from the occipital lobe, and we'll talk about the brainstem circuits that are involved in allowing your eyes to track something. Okay, then there's another extremely powerful pathway called the vestibular ocular reflex. Okay, and so this, the semicircular canals are very important for this. And essentially, this is what allows you to fixate on something and move your head all over the place, and yet your eyes are always able to fixate. Okay, you use this for every millisecond of every day. Every movement you make, walking, your eyes are always perfectly coordinated with movement. Okay, if it wasn't like that, if you've ever seen like these, especially the older cops shows where someone's carrying a camera as they're running into the house and everything is bouncing up and down, okay, that's what every movement would look like for us if we didn't have this vestibular ocular reflex. And this is actually much more powerful than the visual pursuit reflex. And if you just want to convince yourself of that, hold your hand in front of your eyes. Okay, go ahead and do that. All right, and so just follow your hand as it goes back and forth, okay? And then move your hand faster and faster and faster, and eventually it just blurs, right? You're not able to track your hand moving that fast. Okay, but now do this. Hold your hand in front of your eyes and move your head back and forth, and now move your head back and forth faster, and you actually do quite well being able to fixate on your hand, right? So that just shows that the vestibular ocular reflex is incredibly powerful. Now the other pathway is, and actually this is the one that we're going to talk about here in this lecture, is eye movements that redirect the line of sight. This is saccade is a fast eye movement, and this allows you to look quickly from one side to the other. Okay, this is the pathway that originates from the frontal eye fields that we've talked about on the middle frontal gyrus. Okay, so first on the vestibular ocular reflex, we said this fixates the image on the retina with respect to head movements. There are a couple of different ways that we can assess the vestibular ocular reflex. One is called the oculocephalic reflex, and many people clinically call this the doll's eyes reflex. And essentially, we usually do this in an unresponsive patient. We're trying to get some information about these pathways. So the patient is maybe in a coma, okay, and you come by and the patient can't follow commands to track your finger and all of that, so you just lift up the eyelids and you move the head back and forth. Okay, and the normal reaction here, if the vestibular ocular reflex is intact, is when you move your head to the right, the eyes go to the left. You move your head to the right, to the left, the eyes go to the right. Okay, so if we're moving the head back and forth and the eyes are appropriately moving in the opposite direction, then that tells us the vestibular ocular reflex is intact, which tells us some things about cranial nerves, but also a lot of brainstem circuits that we're going to show here in just a minute are involved in this. So it tells us that a good chunk of the brainstem is functioning if you've got a nice intact oculocephalic reflex. Okay, we may get to, at the end of this lecture here, the cold caloric reflex, where you inject cold water into the inner ear. Okay, and as the tympanic membrane gets cold, it actually stimulates flow of endolymph in the semicircular canals. And so we're able to activate the vestibular ocular reflex via that as well. Again, that's usually something we do in a comatose patient. All right, so let's talk about eye movements that redirect the line of sight. And this is a pathway that we will come to again and again. So you really have to understand this. All right, and so blue here is the neurons here are the frontal eye fields in the middle frontal gyrus. Okay, And so we're just going to say we're looking at the left hemisphere here. The patient is looking at the screen. All right, so this is the left eye and the right eye. Okay, and before we get into all the circuits here, the big picture is that the left frontal eye fields are always trying to push your eyes to the right. The right frontal eye fields are always trying to push your eyes to the left. And normally they're equally counterbalanced. Okay, unless you're wanting to look in one direction, and then one becomes relatively more active than the other. All right, so the left brain wants to drive the eyes to the right. Okay, and here's how it does it. Okay, it has to travel all the way down to the pons to an important nucleus here called the PPRF, which stands for the paramedian pontine reticular formation. And think of the PPRF as the area in the pons that coordinates horizontal eye movements, looking from side to side. The PPRF is intimately part of the sixth nerve, the abducens nucleus. It's sometimes called the PPRF sixth nerve complex because they're all kind of tied together there in the pons. Okay, which makes sense because the sixth nerve talks to the lateral rectus muscle. LR is lateral rectus. Okay, and so we've already accomplished half the goal, which is that the right eye is now looking to the right. Okay, but of course, to get the left eye to follow along, that's the medial rectus. Medial rectus is supplied by the third nerve. All right, so we somehow need to activate the part of the third nerve nucleus here that will activate the medial rectus. Okay, and so that is accomplished via this very important pathway that crosses over here called the MLF, which is the medial longitudinal fasciculus. Okay, that's the pathway I pointed out briefly in the sagittal section, traveling up through the pons yesterday in lab. Okay, so the MLF you want to associate with how the PPRF is able to innervate the opposite third nerve nucleus that supplies the medial rectus. Okay, and so this is how the left brain is able to coordinate and move both eyes to the right. You had a question? Where this whole pathway originates in the brain, it's in the frontal eye fields on the middle frontal gyrus. All right, now again, it would make this drawing too complex if I were to show you that the same thing is happening here from the right hemisphere. And so, but you want to imagine, they're equally counterbalanced. Now, what is shown in red here is the cortical spinal tract, which remember originates in the precentral gyrus, and we've said is our best example of a pathway involved in movement. And remember, the cortical spinal tract goes through the posterior limb of the internal capsule. Here's the midbrain, so this would be the cerebral peduncle. In the pons, remember it's part of the basis pontis. And in the medulla, we call it the medullary pyramid. And then it crosses right down here at the junction between the medulla and the spinal cord. And again, this is why we say one side of the brain moves the opposite side of the body, okay, because this is going to go down and activate motor neurons in the spinal cord for movement on the opposite side. Okay, so I'll tell you in a minute, we'll give an example of why we want to kind of overlay the cortical spinal tract along with the pathway involved in eye movements. So before we give some clinical examples, does anyone have any questions just about the eye movements there? Does that make sense? Yes. Yeah, we're just looking at the left hemisphere. Right, and it might be helpful to have a really busy diagram showing you the right hemisphere and the exact opposite, but that it just seems like too much information there. All right, so now let's give some clinical examples. First, let's say we have a left middle cerebral artery stroke. Okay, and so which way will the eyes look in the left middle cerebral artery stroke? And so highlighted in yellow here is that now we've destroyed the frontal eye fields. Okay, so with even looking at the brain circuits here, if you just remember the big picture, left frontal eye fields want to drive the eyes to the right. So if you destroy the left frontal eye fields, now the right frontal eye fields are relatively overactive, and they're going to push the eyes to the left. Okay, so With a left middle cerebral artery stroke, what we see here is that the eyes, again, patient looking at the screen here, the eyes get driven to the left. Okay, so we're losing all of this input here to drive the eyes to the right, so the eyes get pushed to the left. And now which side of the body will be weak in a left middle cerebral artery stroke? Well, the left brain is moving the right side of the body, so we have right-sided weakness. Okay, and so weakness on one side of the body is a hemiplegia or hemiparesis. So notice that in a left middle cerebral artery stroke, the eyes look to the left, the right side of the body is weak, and we say that the eyes look away from the hemiplegia. And this is just so helpful. Middle cerebral artery strokes are really common, and so now with some of the emergent treatment that we have available to give patients in the emergency room when they've had a stroke, you want to be able to make a decision very quickly. Where's the problem? What do we need to do? And so if I just walk in and I see the patient's eyes are fixed off to one side and the opposite side of the body is weak, I know right away where the problem is. I'm still going to do a quick neuro exam, but within seconds you can say this looks like an MCA stroke. So eyes look away from the hemiplegia. Most of the neuroscience review books that I see say the eyes look at the lesion. I prefer to say the eyes look away from the hemiplegia, because when you're walking in looking at that patient in the emergency room, you don't know where the lesion is yet, right? And so if the eyes are looking away from the hemiplegia, that tells you where the lesion is. It's left hemisphere, and it's true, the eyes do look at the lesion, but I prefer to say it this way. Okay, let's give another example here. Let's say that we have a lesion in the pons that destroys here PPRF 6 nerve complex. Okay, so I'm leaving the eye movement diagram the same as what's happening from the left hemisphere, but now to make sense, let's draw the corticospinal tract now coming from the right hemisphere, okay, because it's going to travel through the pons. So what happens now if we have a lesion in the right pons? And with regards to eye movements, to answer that question, just ask yourself, what does the right pons normally do? What it normally does is it will drive the right eye to the right, and via the MLF, the pathway generated from the PPRF, now we're losing this input to the left eye to also move the eye to the right. So we lose all of that stimulation to move the eyes to the right. Okay, and so our other pathway coming from the right frontal eye fields going down to the PPRF on this side, not shown, but now that is relatively overactive. And so with a right pontine lesion, the eyes get driven to the left. Okay, but now what side of the body is going to be weak? Well, here's the corticospinal tract. Okay, coming from the right hemisphere. And it is destined to move the left side of the body. So with a lesion here in the right pons, now the left side of the body will be weak. And so notice that with a pontine lesion, the eyes look at the hemiplegia. So if the eyes are looking at the hemiplegia, then you know very quickly, okay, this is not a middle cerebral artery stroke. Now our lesion is further down, and it's typically going to be here in the pons. Okay, this will take a while to sink in, and I would just encourage you to look over this a number of times and then take a blank piece of paper and, okay, MCA stroke, pontine stroke. Can you figure it out just from drawing it out? Okay. Any questions on this one? Why am I not showing the, like over here, I showed you the left corticospinal tract. Well, notice that's traveling through the left pons, so it's not going to be affected, right, in a stroke in the right pons. All right, here's another clinical application. This one's really important, and that is if we have a lesion of the medial longitudinal fasciculus, okay, which classically occurs in multiple sclerosis. In fact, if you see this eye movement, which we're going to talk about here, in a younger patient, they have multiple sclerosis, almost certainly. And so what's going to happen with an MLF lesion? Well, what does the MLF do? Its primary function is to activate the part of the third nucleus that moves the medial rectus. Okay, so if we have a lesion here, which is usually a demyelinating lesion, all these central nervous system pathways are heavily myelinated, by oligodendrocytes, really we have an isolated dysfunction of the medial rectus here on the same side. Okay, so what's going to happen if I have a left medial rectus lesion? Okay, when I look to the left, no problem, right? You don't need the left medial rectus to look to the left. But when I look to the right eye will move out, and the left eye will either get stuck in the midline, or if it's partially intact, it'll move more slowly towards the nose. Okay, and so the eyes become disconjugate in this case then when I look to the right. This eye is out here, and this eye is here, or it's kind of lagging behind as it moves to the nose. Okay, but what makes this really confusing, I'm going to show you a couple of videos here, is the brain doesn't like to see double vision, right? It doesn't want to have two images, so it tries to bring the images together, and so we get some nystagmus in the normal eye out here. It keeps going back and forth like this. It's trying to bring the images together. And so when you look at the eye movements, you want to look at that eye that's moving back and forth. Well, that's the normal eye. Okay, so it's the eye moving towards the nose that is slow that's affected. And actually, these MLF pathways, they're right in the midline. They're right next to each other. When we do brainstem sections, we'll see they're just the right and left MLF. It looks here like they would be far apart, but they're right next to each other. So oftentimes in multiple sclerosis, what we see is an area of demyelination that affects both MLF pathways. So then when we have a patient look from side to side, neither eye moves to the nose very well. Okay? And so that can create quite a bizarre appearing eye movements. All right, so let me show you here a couple of videos of patients. Okay, and so both of these are patients that have bilateral MLF lesions, and we call this an internuclear ophthalmoplegia. Remember, ophthalmoplegia is just a big word for an eye movement problem. Okay, internuclear is because the lesion is between nuclei. It's between PPRF and the third nerve nucleus. Okay, so here are two patients that have multiple sclerosis. And as you look at this, I find most helpful is to look at the bridge of the nose rather than just to focus on one eye. Okay, and what you should appreciate is both eyes are slow when it looks to the nose.
Look at the pan.
He wants to close one eye because he has double vision.
Look at the finger. Pan, 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 finger. Pan.
Can you see that the eye looking to the nose always lags behind? The eye abducts pretty quickly, but then the eye to the nose lags behind. When it looks to the right eye abducts pretty quickly, but the left eye lags behind.
Finger. Pan, finger. Pan, finger.
Okay, and then let me show you one more. And this is done where we kind of eliminate the space between the eyes, if that makes it easier to appreciate.
Look in the distance. Look at my pen. Look at my finger. Pen, finger. Pen, finger. Pen, finger.
You really see that left eye, especially looking to the nose, is really slow.
Finger, pen, finger, pen.
Okay, any questions about that? Yes. Yeah, so the MLF lesion, if I just have a left MLF lesion, that's only going to affect the left medial rectus muscle. Yeah. So both of the examples I showed you were kind of maybe lesions that were like this, that it got both MLF pathways. Okay? Yes? Would that show up before other symptoms of MS? That could be the initial symptom of MS. In fact, if you have a younger person, we'll talk about MS as a disease of younger people. And if you have someone with double vision in their 20s or 30s, that MS would come to the very top of the list. And this might be your initial finding. I have seen a number of patients where this was the first thing they had, an MLF lesion. Yep. So even before you do a brain scan or anything like that, you're thinking MS. So what you just saw there is an example of nystagmus. So nystagmus, where the eyes are jiggling basically, is a rhythmic, oscillatory, involuntary movement of one or both eyes. Did you have a question? So the question was here, will both eyes be affected? Well, they are in the sense that they're both being driven in one direction. Right? So yeah, both eyes in that case will be kind of forced off to one side. Well, why is this eye affected? Because you're losing this driving pathway to the opposite MLF. Okay, so we'll talk quite a bit about nystagmus, which we see all the time on examination, and you just need to observe the eyes. Horizontal nystagmus is when the eyes are shaking back and forth. Vertical nystagmus is when the eyes are shaking up and down. And rotatory nystagmus is where the eyes are doing this. Okay, they're rotating. Okay, and all the different nystagmus is quite complicated, but different types of nystagmus can really tell us where the problem is. And then we also talk about nystagmus as having a fast and a slow component. So for example, in this type of nystagmus, notice that it's moving fast to the left and more slow back to the right. Okay? And so nystagmus usually has a fast and a slow component. And arbitrarily, we name nystagmus by the fast phase. Okay? So in this example, we would call it a left beating nystagmus because the fast phase is to the left. Okay? So when you see this, you have to have some way of communicating. And if you're reporting on rounds, I see some left beating rotatory nystagmus, then everyone can kind of imagine what it is that you saw in the patient. And so there are different types of nystagmus. Some is physiologic, meaning we see it in normal patients. It doesn't mean anything bad. So in position nystagmus is where quite commonly, if you have someone look very far off to the extreme and hold their gaze out there, the eyes will jiggle a little bit. That's normal. Okay, that's called in position nystagmus. And we don't get too excited if that's all we're seeing on exam. Optokinetic nystagmus is where you really simulate the experience of riding on a train, right? Where you watch something, you follow it, and then your eyes catch up, and they track something else, and you follow it, and then you catch up again. Okay, that's called optokinetic nystagmus, and we have different things in the neurology clinic. I showed here, this is called an optokinetic drum, where you can just spin that in front of the patient, and it's a reflex you can't suppress. You're going to track that for a while, and then you're going to catch up with something else. And so you can bring out that optokinetic nystagmus. All right, so there'll be a number of reasons we might want to do this. I don't do this routinely, but I would say one of the more common reasons we do this is if we think maybe we're dealing with functional blindness, meaning it's maybe more of a psychiatric issue. So I remember distinctly seeing a lady several years ago who came in blind, and her neuroexam was normal, brain scan was normal, we couldn't figure out what was going on, and so we kind of held her eyes open, and we would spin this drum in front of her eyes, and we saw very nicely the slow and the fast phases of the nystagmus, and you're not going to get that if you're blind, that information is not getting in at all. And so the fact that she had nystagmus told us that all these pathways are intact and that this was more of a psychiatric issue. And that was very interesting because in getting into it, more detail, it turned out she had witnessed a murder and she had to go to court to testify. It was very stressful, and so this was kind of a reaction to that stress. Okay, and she eventually, after a few days, suddenly her vision came back again. Caloric nystagmus is something I'm going to show you here, hopefully at the end of the lecture. That's where you put that cold water, typically in the inner ear, and that makes the eyes move. Okay, so we'll come back to this. Now, if we see nystagmus, we always want to think about central nervous system problems, which generally fit into these three in terms of localizing areas. Either with the vestibular apparatus in the inner ears, so there's semicircular canals and the eighth nerve as it enters the brainstem lesions, and cerebellar lesions. Any lesion in here will give you nystagmus. So notice that nystagmus is not something that we're going to see with lesions up in the hemispheres, the telencephalic structures. Okay, this is posterior fossa, brainstem, cerebellum, or the vestibular, eighth nerve vestibular apparatus. Okay? Now, a medication that we will talk about next year, it's a commonly prescribed seizure medication called phenytoin, is well known to cause nystagmus. So when we have patients on that seizure medication, I always look at the eyes. And if I see nystagmus, that suggests the patient is getting too much phenytoin. Congenital nystagmus, where someone is born with this is a very complicated area, but this is actually quite common. So if you see someone with nystagmus, you can just ask, if you had this your whole life, and if so, it's probably congenital nystagmus. Okay, trigeminal nerve. A little faster here. So we can check the trigeminal nerve by just lightly touching on the face in different areas, or sometimes we'll take something that's cold or a little pin to check pain sensation. And so the trigeminal nerve has an ophthalmic division. Notice that the cornea here is in the ophthalmic division of the trigeminal nerve. Okay, then V2 is kind of this maxillary distribution, and then the mandibular branch of the trigeminal nerve here follows the jawline. Okay, so this is touch, temperature, pinprick or pain sensation on the face, and general sensation for the tongue, just the feeling that the tongue is being touched. That is trigeminal nerve. Okay, taste, which we'll come to in a little bit, is mainly seventh nerve, but general sensation for the tongue is 5. Now, in terms of what is supplied inside the hemispheres for the trigeminal nerve, this actually is quite important when we talk about migraine headache later. But the falx cerebri and cerebellar tentorium, which we've talked about quite a bit so far, are supplied by the V1 distribution of the trigeminal nerve. Okay, the anterior middle fossa, so anterior fossa, the frontal lobes project into the anterior fossa. The temporal lobes kind of rest in the middle fossa. The meninges here are supplied by V2 and V3 branches of the trigeminal nerve. Okay, and once we're under the cerebellar tentorium, when we're in the posterior fossa, this whole area is supplied by the C1 to 3 nerve roots. Okay, and again, we will come back to all of this when we talk about headache later in the course. But here in green, we see the falx cerebri and the cerebellar tentorium. Okay, so again, that is V1. And if we look on top of the brain here, we can see the middle fossa. So you can kind of imagine the temporal lobe resting right there, and the anterior fossa, the frontal lobe projects forward. So that's V2 and V3. And then under the cerebellar tentorium, so we've cut it away over here. Now we're looking down into the posterior fossa. Okay, here's the foramen magnum, that opening. And so all of this is going to be mainly C1 to C3 nerve roots, okay, that will supply the meninges in the posterior fossa. So a reflex we can do to assess the trigeminal nerve is the corneal reflex. But just like the pupillary light reflex, this involves 2 cranial nerves. And so it's 5 and 7. So 5 is afferent. Okay, so here's the cornea. Remember, that's the V1 branch of the trigeminal nerve. And so what we'll do is we'll usually have a patient look off to one side. We'll take a wisp of cotton and just lightly touch the cornea. Okay, and so that information goes in. Here's the trigeminal nerve, and this upper portion here is the V1 branch of the trigeminal nerve. Okay, and this goes down and stimulates the facial nuclei, the facial nerve, and not really shown in this diagram, but this actually goes back and stimulates bilateral facial nerves. The facial nerve closes the eye. All right, so the normal reflex here when you touch the cornea is that both eyes close. Okay, so in this case, we're stimulating the left trigeminal nerve, and the output is bilateral facial nerves to close the eye. And I don't check this routinely, and again, this is something we often check in a comatose patient, and you're trying to figure out where the problem is. And so if you touch the cornea in someone who's unresponsive and both eyes close, well, that tells you that cranial nerves 5 and 7 are working. And more importantly, really, it tells us that a good portion of the pons is intact. Okay, so we're assessing 5 and 7, which we'll see later are located in the pons. Okay, the trigeminal nerve has a smaller motor branch, okay, that supplies several muscles, the temporalis, the masseter, and the lateral and medial pterygoids. Okay, the jaw closure, we can check this on examination by having the patient close the mouth tightly open, and you can give them some resistance. Jaw closure is the medial pterygoids, the masseter, and the temporalis all work together to close your mouth. Jaw opening is primarily a function of the lateral pterygoids. Okay. In the second year course, we'll talk about a condition called dystonia, where you have a sustained overactivation of certain muscles. And there is a jaw opening dystonia where patients have this overactivation of lateral pterygoids, and they walk around all the time with their mouth open. Okay, and so you can inject Botox into these muscles, and it's very effective. But anyway, just as a reminder here, lateral pterygoids for jaw opening. Side-to-side jaw movements, it's the opposite, mainly lateral, and also some medial pterygoids that push your jaw to the opposite side. So you can have a patient wiggle their jaw back and forth, and you're checking the pterygoids when you do that. Okay, a reflex that we can do to assess the trigeminal nerve, that when we go through our brainstem sections, I'll tell you the clinical significance of it at that time. You just have the patient open the mouth a little bit, and you can tap on the jaw. It's kind of a hard reflex to elicit, but if it's intact, you'll feel the jaw kind of snap back up against your finger. Okay, and this is 5 afferent and 5 efferent. So we're checking both afferent and efferent trigeminal nerve when we do that. All right, the facial nerve supplies all the muscles of facial expression. And so we'll have the patient raise their eyebrows, close their eyes, smile, puff out their cheeks. And so forehead and lower face, all of that movement is facial nerve. Okay, just a little break here because I want to just prepare you a little bit for the upcoming examination. We don't have a practical in neuroscience where you're actually walking through sections that have pins in it. So we used to do that, but we're kind of replicating what you see on board examination. So you'll get a section like this with an arrow pointing to something, and so it might be a brain section here, and maybe an arrow is pointing to this. Okay, so what is this nucleus here? Bless you. Lateral geniculate nucleus, Napoleon's hat. Okay, and so again, as much as possible, we try to make things clinical in this course. So what do we know about the lateral geniculate nucleus? Well, we talked about that with vision, getting back to the brain. So a lesion here might result in which of the following? That would be the type of question that I would usually ask. And then you'd have to pick some sort of visual loss rather than loss of smell or hearing loss or something like that. Okay, here's a nice look at the midbrain. Okay, better than the brain I dissected yesterday, but we can see the cerebral peduncle. There's the subthalamic nucleus, red nucleus, cerebral aqueduct. So lots of pictures on this upcoming exam, but they're all integrated into into all of the other questions, not a separate practical. All right, so just coming back to the facial nerve. This is the first time we'll mention this term, which will be really important, but in neurology we talk about upper motor neurons and lower motor neurons. So the facial nucleus here is a lower motor neuron, which by definition, a lower motor neuron is a neuron that talks directly to muscle. So notice that the axons here from the facial nucleus are going directly to muscle. Okay, in this case, to raise your forehead, this is frontalis muscle, or to close the eye, to smile. Okay, so this is a lower motor neuron here that is activating facial muscles. Okay, all lower motor neurons have upper motor neurons that regulate them. Okay, and so the facial nucleus itself here has an upper motor neuron pathway that comes from the opposite hemisphere. Okay, and notice here, this is the cortical bulbar tract. Okay, we talked about that pathway as it travels through the genu of the internal capsule. And so what is the cortical bulbar tract? Well, it's the connection between the cortex and the bulb, which is the brainstem. Okay, and so the cortical bulbar tract is how the brain regulates and controls all of the cranial nerves. And so notice here the cortical bulbar tract, you know, when you move your face, of course, that's not going to be the facial nucleus, quotes, deciding to move. It has to come from the brain. All right, and so it activates the opposite portion of the facial nucleus for the upper and the lower face to move your face appropriately. But now notice that the facial nucleus here is divided in half. Part of it is for the upper face, so we could follow this to the forehead, and part of it is for the lower face, and we could follow this to the lower face. Okay, so the contralateral cortical bulbar tract innervates the upper and lower facial division, but there's also an ipsilateral supply here from the same hemisphere, but notice it is only going to the upper face division. So the supply, the upper motor neuron supply for your upper face is dual, both hemispheres. Whereas the lower face division only gets a contralateral supply. Okay, so why is that important? Well, first let's imagine we just have a lesion of the facial nerve. And the most common cause of that is Bell's palsy. Okay, very common. So we have injury here to the facial nerve, Bell's palsy. And so this would be a lower motor neuron lesion, right? Because this whole thing, from the facial nucleus to the face, these are lower motor neurons. All right? And so in a Bell's palsy or a lower motor neuron facial weakness, notice it's going to be the upper face and the lower face that's affected. Patient can't raise their eyebrow, they can't close their eye, they can't smile. It's the whole side of the face. Okay? But now let's say that we have a stroke, maybe in the genu of the internal capsule, affecting the contralateral cortical bulbar tract. That's going to look a bit different. And it'll look different because we have an ipsilateral supply that is going to be preserved. So the upper face division is not affected with the lesion of the cortical bulbar tract, but the lower face division will, because notice it's only getting a contralateral supply. And so when we have a stroke, we will see it's mainly just the lower face that's affected. Okay, so when we see a patient in the emergency room for facial weakness and it's just the lower face, we're actually much more concerned about that patient. That would suggest more a lesion up in the brain. When we see one whole side of the face affected, well, that's the facial nerve. Usually, not always, that's Bell's palsy. Great prognosis. We can send that patient out of the emergency room, typically. Okay, so here's some pictures of patients with facial palsy. So notice when the patient smiles, we get nice, healthy wrinkling here on this side. Not much is happening over here. Notice also that the facial nerve, remember, closes the eye. And so this eye looks open a bit wider because you lose that supply to close the eye. Okay, here's a patient with now right facial palsy. Notice that the eye is open a bit wider, and she is only smiling on this side of the face. Things are fairly flat over here. Okay, we ask her to close the eyes, and normally when you try to close your eyes tightly, you should be able to what's called bury the eyelashes. Okay, this is a good example of that. She can't do that over here. So we see the eyelashes, so there's weakness with eye closure. Okay, and here's a patient. Again, we see, notice the wrinkling here on the frontalis up here. That's normal. This is flat. So the forehead is weak. This eye is open wider. We see facial expression over here, not on this side. He closes the eyes tightly. Notice he can't do that completely over here. Okay, and so this is what we'd see in a facial paralysis. Now, let me just, I'm going to show you a video, but let me just show you a couple of other things about the facial nerve first. So I said trigeminal nerve is sensation for the tongue, general sensation. Taste to the anterior two-thirds of the tongue is the facial nerve. We don't do this very often, but you can occasionally, if there's a patient complains of it, you can put sugar or salty solutions and assess that. Okay, but the facial nerve also supplies this muscle called the stapedius muscle, which is important for dampening sound. Okay, so when you hear something really loud, the stapedius is activated to try to diminish the intensity of that sound. So therefore, when we have patients with Bell's palsy, you lose that supply to stapedius, and so they're not only going to have facial weakness, they usually will say sounds are louder in that ear, and quite irritating often. Okay, so now let me, before we show the video, I just wanted to show one thing from the handout, because almost every review book will show you a picture like this. Okay, and so a central 7, so this would be like a cortical bulbar tract lesion. Notice it's just the lower face that's weak. And in a Bell's palsy, they're trying to indicate that the entire side of the face is weak. But what is very misleading is almost all of the drawings show this, where the eye is more closed than the other eye. And all the pictures I just showed you, the eye was open wider. Well, acutely, in a Bell's palsy, the eye is wide open. Patients can't close it. What happens is, over time, you get what's called aberrant reinnervation. The facial nerve is trying to go back and resupply those muscles, and it ends up not regrowing properly. And so that can sometimes cause the eye to be closed more. But that is just in the recovery phase, a poorly recovered Bell's palsy. But if you can just remember that typically, you see that patient in the emergency room, this eye is going to be wide open. Okay, so now let me show you here a video of a patient with this.
Yes. One night I went to sleep and I woke up the next morning, and the next morning I felt numbness and drooping of the mouth, and forehead couldn't move.
Remember I mentioned numbness is about the most non-specific word that you can use. So the trigeminal nerve is not affected here. Sensation is normal, but patients will still use the word numbness. And you just notice if you watch him blink, he's blinking a lot here. We don't see that much over here because of the facial weakness.
They diagnosed me as having Bell's palsy. I've been like this for about 2 months now.
Okay.
And I have numbness.
Now, when this all started, you had a lot of pain. You were telling me, like around the ear area,
yes.
You were having a lot of pain.
All around the back ear.
It's usually how it
and up
starts
in the
out with
face
some
and
pain.
the head area.
Okay. Now, you have a problem moving the forehead.
Yes.
And
It's hard to move my eyebrows up
Nothing happening here.
from the forehead.
Okay.
And
And
my mouth has a droop on the left side lip.
okay. And you have a hard time closing.
I have a
that
hard
left
time
eye.
closing my left eye all the way.
Okay. Now, you were telling me also that with sounds, that you feel like sounds are a little bit louder
Yes,
in that
a little
left
bit
ear.
louder. I have a tendency to kind of make me bow to the side of a loud effect, loud sound effect.
Mm-hmm. Okay.
All right, any questions there on about Bell's palsy? Yes? Yeah, what causes it? So we'll get into that. The Bell's palsy is kind of complex, so we'll definitely talk more about that. Yeah. All right, so let's get on to the 8th nerve here. The 8th nerve, if you look at it in the brain, it kind of looks like there are 2 nerves tied together. Okay, that's because the 8th nerve has an auditory and a vestibular component. So the auditory or the cochlear division, we can check this on examination by just lightly rubbing your fingers and come closer to the patient and ask them when they can hear. We can compare that side to side. A ticking watch, I don't know, does anyone still use those? But that's something else that you could use. And so just in terms of types of hearing loss, here are the 2 big categories of hearing loss. We can have a conductive hearing loss or a sensory neural hearing loss. And just to show you a picture, here the conductive hearing is where we have air here in the sound waves and the ossicles. Okay, and the sensory neural here is where air conduction gets converted to bone conduction. And so a lesion here of the cochlea or the eighth nerve, this would be called sensory neural hearing loss. So for example, we talked about an acoustic schwannoma. Remember that tumor that can compress on the eighth nerve? Well, that would be an example of a sensory neural hearing loss. A conductive hearing loss would be something like maybe a child that keeps having ear infections. Okay, and so they certainly could lose some hearing the more they have, and so that would be an example of a conductive hearing loss. You know, a lot of middle ear infections and so on. And so if someone complains of hearing loss, we could do a couple of bedside tests to evaluate that. Okay, one is called the Weber test, and you take a vibrating tuning fork like this and you just tap it, it buzzes, and you put it on the vertex and you ask the patient, does it sound about the same to you in both ears? Okay. Now, you will realize as you begin to do the neurologic examination, patients really want to help you. And so they might say, it's a little bit more in the right ear. Well, you know, you want to, is there a convincing difference? Is there, you know, is a small difference or not? So we don't want to overinterpret, you know, things like that. But lateralization to one ear, if it's significant, is abnormal. Okay, with sound localizing to the bad ear in a conductive hearing loss, and we can simulate that. If you just put your finger in one ear, okay, you've just caused a conductive hearing loss. Right now, if you were to hum, because you block out all of the external sound, you're going to hear it louder in that ear. Right? So in a conductive hearing loss, you may need to go home in a quiet room and prove that to yourself later, but the sound will localize to the bad ear in a conductive hearing loss. Okay, now if we have a sensory neural hearing loss, let's say we've got again an acoustic schwannoma, well there the nerve is just destroyed, and so if you do the Weber testing there, the patient is just going to hear it in the other ear. Okay, so this will differ depending on which type of hearing loss that we're dealing with. Okay, so the test that we want to always do with that is the Renee test. Okay, where you take your vibrating tuning fork and again you tap the hammer and you put it on the mastoid ear process. It's very loud. Okay, and then you can do this a couple of ways. You can wait until it stops and the patient says, yeah, I can't hear it anymore. And then you take the prongs of the tuning fork and you hold it up to the ear. Okay, air conduction is normally much better than bone conduction. So the patient will say it stops when you're holding it here, but yet when you move the prongs around, they'll say, oh yeah, I hear it again. Okay, so the normal is that air conduction is greater than bone conduction. And so if you see a reversal where now bone conduction is greater than air conduction, that suggests we have a conductive hearing loss. So again, let's say we have a child here that has a lot of ear infections. They have a conductive hearing loss. And so again, if we just imagine here bone conduction, well, that's going to stimulate this area and the eighth nerve quite well. That's not going to be affected. But air conduction will be affected. So that's why you lose the air conduction dramatically in a conductive hearing loss. And so if you're answering we'll talk about hearing loss and all the causes in the second year. But if this is reversed, okay, bone conduction is greater than ear conduction, you know, okay, I'm in the conductive hearing loss category. Okay? Whereas if we have a sensory neural hearing loss, again, let's say an acoustic schwannoma, the end output, the nerve is affected, so both air conduction and bone conduction are reduced. Okay, but the relationship between them is the same. We're still going to see air conduction greater than bone conduction. Okay, so oftentimes it's the reversal here that will jump out at you on a test vignette and say, okay, it's a conductive hearing loss. Okay, so let's stop there and we'll finish up the rest of the cranial nerves tomorrow.